Now, whenever someone's cardiac function is reduced, it increases their risk for chronic heart failure. And we'll talk about that in a second. So anytime cardiac output is reduced or cardiac function is reduced, it increases the risk of chronic heart failure. Anytime the cellular architecture of the ventricles change, like with this remodeling and the laying down of fibrotic tissue, it increases the likelihood of arrhythmias. And whenever you have increased arrhythmias, it increases the risk of fatal arrhythmias, like ventricular arrhythmias. Okay? And a fatal arrhythmia is sudden cardiac death. So this individual has now high risk for sudden cardiac death, arrhythmias and sudden cardiac death, and high risk for chronic heart failure, post-MI. Okay. So let's talk about heart failure. Let's talk about heart failure. Heart failure happens at the most basic definition. Heart failure happens when the heart cannot generate an adequate cardiac output to meet the body's metabolic demands. Cardiac output is the performance function or performance measure of the heart. When it can't produce an adequate cardiac output, that's when the heart failure happens. And heart failure can be acute or it can be chronic. It is usually chronic. Acute heart failure can sometimes be in the form of fatal myocardial infarctions, like that proximal LAD obstruction. It can be in the form of sudden cardiac death, which is a result of fatal cardiac arrhythmias, where there is an increased risk of that whenever you get any kind of myocardial remodeling, right? That comes along with healing from an MI, or left ventricular hypertrophy also is considered myocardial remodeling. Okay? Or sometimes acute heart failure can happen when you have what's called acute decompensation of chronic heart failure. And normally what happens with that is the person has acute volume overload, okay, where their blood volume expands so significantly and so rapidly that it causes fluid to back up in the lungs and can be very life-threatening. Okay? And so we'll understand in just very shortly what expansion of plasma volume and chronic heart failure have to do with each other. But that's what that's one way to get to acute heart failure. But normally, heart failure is chronic. And there's 4 basic categories in terms of causes of chronic heart failure. Abnormal cardiac muscle function, which is very common, especially in terms of post-myocardial infarction, but some of these cardiomyopathies, which some of them are genetic and some of them are acquired. Abnormal left ventricular volume. So when you have valve insufficiencies, it can expand the left ventricular volume and cause heart failure. Blood volume expansion as a result of things like chronic anemia or infusion of large IV fluids in a short period of time. It just overwhelms the heart, and the left side of the heart can't handle it. Abnormal left ventricular pressure as a result of hypertension or COPD. Abnormal left ventricular filling because of valve abnormalities or AFib. These are all basic categories for causes of chronic heart failure. Now, heart failure can start off in either the right side of the heart or the left side of the heart, depending on the cause, the original cause. But it doesn't matter where it starts, because left-sided heart failure eventually leads to right-sided heart failure. Right-sided heart failure leads to left-sided heart failure. Okay? So it can start out in one side or the other, but eventually it's going to cause failure on the other side. So right-sided heart failure tends to happen when the right side of the heart is actually forced to work hard at all, because the right side of the heart is not actually designed to generate high pressures. It's designed to generate just enough pressure to pump blood into the pulmonary circulation, which should be a very low pressure system. Okay. Times where the pulmonary circulation the pressure becomes high, it's called pulmonary hypertension. An example of this is people with COPD. Okay. With COPD, you end up with a deoxygenation of the blood in the pulmonary circulation. And the pulmonary circulation is unique in that when oxygen levels go down, pulmonary vessels tend to constrict. Okay. So when oxygenation of the blood goes down within the pulmonary circulation, those pulmonary arteries tend to actually constrict. And when they constrict, it raises pulmonary pressure, and then now it increases that right-sided afterload, right? It increases the pressure that the right side of the heart has to work against. So you get this right-sided heart failure, and so blood is not getting passed on away from the right side of the heart. You get congestion of peripheral tissue. So you can get dependent edema and potentially ascites. You get GI tract congestion, which can result in GI distress or loss of appetite. You can get liver congestion, which can cause liver enzyme impairment or abnormal liver enzymes or that kind of thing. When the right side is not, when the right side fails, it's not pumping blood onto the left side, and left-sided cardiac output goes down, right? And so you get a decreased cardiac output. When the reason why the left side might fail first, okay, the reason why the left side might fail first could be chronically elevated arterial pressure. So the pressure in the arterial system is very, very high. The left-sided cardiac muscle is just not strong enough. Okay. And so when the left side fails first, in addition to that decreased cardiac output, you get blood sort of backs up in the lungs. You get pulmonary congestion, which impairs gas exchange, can cause pulmonary edema. Okay. The decreased cardiac output is going to cause different levels of activity intolerance. If you can't pump blood into your system, into your systemic arteries, you're not going to be able to deliver enough oxygen to be able to maintain activity. Okay. So if the left heart fails first, that pulmonary congestion increases pressure in the pulmonary circulation, and it causes right-sided failure. Yeah. If the left side fails first, that pulmonary congestion, that causes increased pressure in the pulmonary circulation and increases the workload on the right side, and you get right-sided heart failure. Okay. Now with chronic heart failure, which is usually associated with the left-sided failure, okay? With chronic heart failure, there is a dynamic that the body gets engaged in, where with chronic heart failure, usually what's going on is it starts with a fairly modest decrease in cardiac output. When your body experiences a decrease in cardiac output, it attempts to recover that cardiac output. Okay? It's a little like registering blood loss. Okay? So the body sees cardiac output go down, and it tries to stimulate an increase in cardiac output. So how does the body, what are some of the ways that you know of that the body stimulates an increase in cardiac output? So let's hold on to that for a second. What's that? Increases heart rate, right? If you increase heart rate, maybe we can get more blood pumping. Increase stroke volume, increase contractility, right? Try to get the heart to contract harder, right? Interestingly, the increased heart rate and the increased contractility go along with sympathetic stimulation, right? Which actually it tends to cause increased blood pressure, right? So the pressure goes up, your heart rate goes up, your contractility goes up, and also your body increases blood volume to try to get more volume going. Now, what do all those things do to the heart? Increases the workload on the heart. Increased heart rate, increased contractility, increased blood pressure, increased volume. All of those things increase the workload on the heart, increases oxygen demand. And if this is a heart that's post-MI, that there's already some coronary disease going on, this is a heart that's getting set up for even more ischemia, even more damage. And that the more ischemia and the more damage causes an even further decline in cardiac output, which is responded to with even more of this compensation, right? Even more of this compensation that increases the workload, increases the volume. And so chronic heart disease is a vicious cycle of declines in cardiac output and adaptations that actually increase the workload on the heart and cause more damage to the heart. Okay. And so as we'll see in a moment, the treatments are actually designed to limit the body's adaptations to decrease cardiac output, okay, in order to preserve heart function. So two important components that represent chronic heart failure. We have structural remodeling of the cardiac tissue that results in reduction of cardiac function, right? So this happened, let's say the person had an MI, right? And so they've got now cardiac remodeling and reduced cardiac function and reduced cardiac output. And the second part is multiple compensatory events that are a response to decreased cardiac function. And it really makes up the majority of the pathological problems with chronic heart failure. Okay? So the first step is a reduction in cardiac function. The second step is the body's response. And in fact, the body's response is the problem, okay, that causes the downward spiral. So the decline in cardiac function we talked about. What are some of these responses? And we mentioned some of these. These are the responses, they're sort of collectively called the neurohormonal responses to decrease cardiac output and stroke volume. You get activation of the sympathetic nervous system, right? You get activation of the renin-angiotensin system, and you get increased release of antidiuretic hormone and something called atrial natriuretic peptide. And the net effect of these is to produce arterial vasoconstriction, right? To produce venous vasoconstriction in order to increase blood flow to the heart and increase blood volume. Atrial natriuretic peptide increases the responsiveness of the vascular smooth muscle. It increases the contractility of the vascular smooth muscle. Yeah. BNP is brain natriuretic peptide, which I actually forget what that's supposed to be a measure of. Heart failure. Yeah. get back to you on that because it's, I know I mean, it may have undergone a change in name that I'm not aware of, but atrial natriuretic peptide is something that's released when the atria become stretched. And so certainly what I know is A&P will go up with increased blood volume, which will certainly go up with heart failure. But that's a really important question that I will definitely get back to you on. Did you have a question, or was it just?
No, just I know it's probably made by the
What's that?
room dividers.
That's the room dividers?
I bet, because when they hit the wall too far, it shakes it.
Well, that's terrifying. All right. So we're going through this in different ways, the same sort of concept, right? So we get a drop in cardiac output, which causes an increase in sympathetic stimulation, right? And so, we always get that. Whenever we have a drop in cardiac output, our sympathetic nervous system kicks in. Because it's a generic response, it thinks that you have lost blood. Okay? Sympathetic stimulation increases heart rate, it increases contractility, it increases blood pressure. Decreased cardiac output is also going to reduce blood flow to the kidneys, which is going to increase renin-angiotensin system. So you get increased angiotensin, which also causes constriction. You get production of aldosterone, which is going to cause sodium and water retention. Increased blood volume, okay, so that you can send more blood to the heart. Okay. So what does this all mean? When our heart rate increases, our contractility increases, that increases the oxygen demand on our heart. When we cause an increase in vascular tone, when we increase blood pressure, that increases the afterload on our heart. When we retain fluid and expand our plasma volume, that increases the preload on our heart. Yes, ma'am? Under what circumstances? I'm not sure. Like hypotension? Yeah. Well, what it's going to do, if you have hypotension because of, let's say, inappropriate dilation, it's going to cause constriction. It's going to recover their blood pressure. So it really depends on what the drop in pressure is caused by. Yeah. I'm not sure I know the context of when you would give this and why and what the... In sepsis, yeah. So in sepsis, what you're really just trying to do is recover blood pressure. Because with sepsis, what you have is a normal blood volume, right? You're not hemorrhaging, but you have inappropriate dilation. So giving them more volume is not as effective as just trying to get them to press and increase the, yeah. Okay. So all of these responses assumes that you have a heart that can participate in this, right? But instead, this is someone who has a weakened heart. So all of these natural responses by the body is going to increase the workload on the heart and cause more damage. Okay? Oh, let's skip that. So when you're talking about treating heart failure, okay, let's talk about the drugs and work backwards. You're talking about treating heart failure. All of the drugs that are used to treat chronic heart failure are designed to minimize the body's natural responses to a drop in cardiac output. So you've got things like ACE inhibitors. ACE inhibitors are going to reduce the production of angiotensin II, which is going to reduce the volume overload. It's going to reduce the vasoconstriction caused by the angiotensin II. Okay? and it's going to help limit this activation of the renin-angiotensin system part of the equation. Angiotensin receptor blockers is similar, but specifically they're blocking the receptors to angiotensin. Aldosterone antagonists specifically aimed at limiting sodium and water retention, right, caused by the aldosterone. Beta blockers. A beta blocker is going to have what effect on the body? It's going to tend to decrease heart rate. When we decrease heart rate with a beta blocker, what we're trying to do is reduce the oxygen demand on the heart. Reduce the heart rate, you reduce the oxygen demand on the heart. Okay. And by doing that, you're trying to preserve cardiac function. Digoxin specifically tends to increase the contractility of the heart, which is something that's given in the much later stages of heart failure, tends to be given to people who are elderly especially, and it's actually it's not reducing the oxygen demands on the heart, it's trying to maintain minimal heart function if the heart failure has progressed pretty far. Okay. So digoxin is sort of actually the outlier in this theme that we're talking about, where the rest of these drugs are really trying to interrupt the adaptive responses, or not adaptive, but the responses by the body to a decline in cardiac output. And then diuretics. Diuretics are an important part of treating chronic heart failure because they're going to help you limit this fluid retention. Okay, so the diuretics are going to limit the fluid retention. And of course, individuals are going to be on sodium-restricted diets because their body's already trying to retain sodium in water. So they're going to be on sodium-restricted diets. And we've got probably several cardiac nurses here. What time of year do you tend to see the most emergencies with heart failure patients? What's that? Any change? Any season change? And what about like holidays? Yeah. Because they eat the ham, exactly. So the holidays, right? So people have these really sodium-rich, they ignore the dietary restrictions. They get these really sodium-rich meals. And then all of a sudden, they're in fluid volume overload, right? And they're in fluid volume overload. Their left ventricles can't handle the volume. And then what happens? The volume goes where? Into the lungs. Right? And then now they're having shortness of breath, maybe they're desaturating, right? Their oxygen levels are going down. Maybe they are coughing up pink sputum, right? The pulmonary edema. So that's the constellation of problems that went, and that's that potentially that acute decompensation, right? From chronic heart failure, where if you have an abrupt volume overload that causes acute left ventricular failure, pulmonary edema, and hypoxia, right? That can be an acute decompensation of chronic heart failure. Right? So, being able to get rid of that volume is going to be a really important step in controlling that. Oh, okay. So these are the different drugs that are used. Patients with heart failure are stratified in different groups. There are patients who actually don't have heart failure, but they're high risk. And patients that have active heart failure, both current and end stage. And the individuals who are at risk for heart failure, what sorts of things? This A and B category. So the A is, you're sort of the farthest from the end-stage heart failure is possible, right? But you're still at risk. So these are people with hypertension, atherosclerotic disease, diabetes, metabolic syndrome, which is sort of a combination of diabetes and hypertension. Right? These are all individuals that are at risk for myocardial infarction, for cardiac remodeling. Okay? And then the stage B, where you go beyond just this low-level risk, these are individuals who are at high risk for heart failure. So these are people with previous MIs, and they have some left ventricular remodeling already happening. Right? Their ejection fraction is already low. Ejection fraction being the fraction of blood their heart ejects with each heartbeat. Okay? So they already have some lowering of their cardiac function. Okay? So those people are really at high risk for heart failure. Okay? So these are the groups of people that potentially can develop chronic heart failure, and then if they do, the strategy, by and large, is trying to minimize the body's responses to a drop in cardiac output. Okay? Interrupt that vicious cycle, that downward spiral. Okay. Questions? Yes?
If you were a 35-year-old that had MI but were otherwise healthy, and you developed, massive heart failure and stuff like that, could you get put on a heart transplant list?
Oh, yeah. I mean, and I don't think you have to be 35, right? I mean,
Well,
it's,
I know
yeah.
older people who have multiple comorbidities aren't even
And I know that, right. And I know that actually nowadays certainly the cure to heart failure is transplant. But what's actually been very successful now too, it used to be just a bridge to transplant, are these ventricular assist devices. Yeah, and they are mechanical devices that actually assist the left ventricle or the right ventricle or both in producing cardiac output. And so it used to be something that was a bridge to sort of keep people alive until they can have a transplant. But now they're getting more and more efficient, and they're actually becoming sort of a destination where instead of transplant, that's what they're getting. Yeah. Oh, of course. Yeah.
With brain natural.
Oh.
If you're interested.
Yeah. So the way that this is describing BNP is that it's AMP. That it's, that what used to be, what I understand, atrial natriuretic peptide is, I guess, called brain natriuretic peptide now. So yes, it's a hormone that's released by, so it's released by the ventricles. Maybe that's the difference, actually. It's released by the ventricles. But it's released by the ventricles for the same reason that atrial natriuretic peptide is released by the atria. It's stretching on the walls of the heart. And it's natriuretic peptide, meaning that it promotes natriuresis. It's supposed to promote the excretion of sodium, right? That was but it does other things, and one of the things that it does is it increases the reactivity of the blood vessels and increases blood pressure. So.